so much for joining us remotely. I'm going to keep opening very brief, just so we can launch right in. I'm Stephen Fee. I work in the communications office here at PHR. It's my pleasure to introduce my colleague, Karen Naimer, who's the director of our Sexual Violence and Conflict Zones program, as well as Dr. Mike Anastario, who leads our monitoring and evaluation as an independent expert for PHR's sexual violence program. I just want to say, for those who are joining us on the phone, during the more formal part of the presentation, you'll be muted. Please don't be offended. But after both Mike and Karen give their remarks, we're going to open up the line so folks can join the conversation. Also, while the presentations are ongoing, again, for those who are on the line, you can submit your questions using the question tool online, and we'll see those questions here, and we'll be able to read those questions out during the Q&A portion of our conversation. So to start us off, Karen is going to give some remarks about our program. So Karen, I leave it to you.
Thanks, Mike, and thanks everyone for joining us. We thought that it would be really helpful to take a step back and think about where we're at with our program as we conclude our fifth year of doing this work. When the idea first came to one of our colleagues, Susanna Sirkin, to develop this program, we talked through all the different variations that it could take on, and over time the program has really grown and matured and developed in lots of different ways. And I'm going to provide a brief overview of what we've been doing, but it's a particular pleasure for me to have Mike here to be able to share his unique perspective as well, because Mike has been with us since the outset of the program, tracking how we're doing by running an independent monitoring and evaluation initiative to keep us honest and to keep us on track. So very briefly, the program inception. PHR, of course, as many of you know, has been documenting human rights violations for decades. And over the years, many of our colleagues along the way had noted that sexual violence cases were actually some of the hardest to prosecute. Many survivors don't tend to come forward at all to report their cases because the stigma is so great. There's very legitimate fear and risk, of course, of retaliation and re-traumatization. But nevertheless, some survivors do choose to come forward because getting their day in court and facing the accused is very important to them. And what has been so troubling for us, and what really mobilized us to develop this program, is their cases often fail because there's a lack of adequate evidence to support their allegations. Are we able to move the slides forward? Oh, there we go. Right, there's a lack of evidence to support their allegations, which of course ends up accentuating the impunity in these communities. There are many reasons for, the slides are not advancing.
I think you need to direct it towards the screen.
Oh, here? Okay, great. There are many reasons why these cases are really suffering. And what we have noted over time in our assessments in these communities is that some of the big obstacles are forensic exams, forensic medical exams are not conducted, medical charts are not kept, or if they're kept, they're very incomplete or incompletely illegible. And clinicians and police officers, lawyers, and judges, they work in silos, they speak different languages, literally the professional jargon that they each have in their communities of practice, they don't understand each other. And so consequently, there's very little coordination that takes place across these individuals. So 5 years ago, we developed the program on sexual violence in conflict zones to address these issues. And we wanted to develop very concrete strategies and techniques for overcoming some of these obstacles, and specifically for addressing the processes for collecting and documenting and analyzing and preserving forensic evidence of sexual violence to better support local prosecutions of these crimes. We also recognize that there's intrinsic value for justice to be done and to be seen to be done in the very communities where the crimes had taken place. And we also place enormous value on empowering the victims and witnesses in these communities to play a more active role in the justice process. So our goal is to enhance the capacity across these medical and legal sectors to really create sustainable multi-sectoral networks of collaboration. So colleagues can work with each other more effectively on a case-by-case basis to increase the likelihood of successful prosecutions and ultimately to better support the survivor at the center of this process. And that really captures our theory of change. The program was built on the belief that increased accountability for sexual offenses and improved access to reparations for survivors will ultimately deter incidents of sexual violence going forward. We've been piloting this program in DRC and in Kenya over the last 5 years. Because these were countries under investigation at the ICC. So in the spirit of complementarity, we know that most of the cases that occurred in these countries will never get to the Hague. So we wanted to develop stronger institutions at the national level to be able to handle a lot of these cases. Over time, the program has developed an ecosystem, a mutually reinforcing universe with various components that have evolved and changed over time in response to the articulated needs of our partners. So these include training and mentoring, which then begets networks and medical legal networks of collaboration. The networks have come together to identify tools that would allow them to continue working in the spirit of best practices in between the trainings and beyond the trainings. And then these networks have also helped to mobilize around certain advocacy issues, which I'll talk about. And also it's created an enormous research opportunities. And so these activities have informed directly the research that we've undertaken. So I'll just briefly cover some of these different components and how they've taken shape over time. With respect to training, we have been training medical and legal professionals all together in one room to improve the way these service providers work with each other and gather forensic evidence and build cases for prosecutions. So we train these medical and legal professionals that from all these sectors that there is credible forensic evidence to be gathered in the medical clinic that is often a novel idea, and that it's also medical evidence can be really useful even in low resource environments, I would say, especially in low resource environments, and that there's a lot of evidence to be gathered even months or years after the violation has taken place. We've developed a whole range of training curriculums. This is a photo of training on physical and psychological evidence gathering. We've also trained on forensic photography, pediatric evaluations. Many of our partners in these countries have identified that actually pediatric cases are the majority of the cases they see. So we've developed specialized curriculum for that. Interviewing skills, also packaging and labeling of evidence, and of course on documentation. We've also developed new initiatives to train the trainers, which we launched last year, and also a more holistic approach to training at a medical facility called our Institutional Capacity Development Initiative, which looks not only at the individuals at an institution who may be at a medical hospital, who may be treating a survivor, but how the system works at that institution, and does it place the burden on the survivor or burden on the caregivers to allow the survivor to navigate that process a little bit more easily. So we have been working very closely with partner institutions to take that more holistic approach. Overall, I think that it's really critical to identify that these trainings are not a one-off. These are sustained models of collaboration going forward. And of course, as we know, if clinicians do a terrific job and police officers and lawyers do a great job gathering the evidence and presenting it in court, it goes nowhere if the judges don't understand how to analyze and appreciate that evidence before them. So we've also designed specialized trainings for judges, both at the national level and at those judges sitting at international courts and tribunals, for them to be able to understand how to interpret forensic evidence, and in particular forensic medical evidence of sexual violence. Over the last 5 years, we've trained more than 1,600 professionals in DRC, in Kenya, and elsewhere. The training workshops are really a launching pad for larger relationships with these partners. Many of our partners come to us through the trainings, but then they become very active participants in these medical legal networks of collaboration, where partners can then work with each other on a case-by-case basis, and also to pursue certain advocacy initiatives. And in DRC, there was no forensic medical certificate for sexual violence, and our partners in DRC came together in 2012 to create this medical certificate that allows for more comprehensive documentation of sexual violence, forensic medical evidence, and it's legible, which is terrific. It's a low-tech, simple concept, but it really is transforming the power of standardized documentation. It's being used now in civil and military justice processes in eastern DRC, and the form is also featured as a model of best practices by the UK's International Protocol on documenting and investigating sexual violence cases. The networks have also established certain tools that allow them to inform their work between trainings. And so I have some examples of this year training videos and curriculum companions and lexicons that actually create these medical terms in language that is more accessible to law enforcement and legal communities, so they can actually work with each other more effectively. We've also been experimenting with more high-tech tools, and we are in the process of developing Medicat, which is a mobile app that allows clinicians to pair the forensic certificate with forensic photography and to pair that information and share it with the police. We've been field testing this in DRC, getting the feedback of the end users as we go. So this is called collaborative design, so that ultimately the app that will be completed in hopefully a few months will actually serve directly the articulated needs of these partners in these communities. The networks that we have cultivated have also, as I mentioned, mobilized for advocacy purposes. So in DRC, I mentioned the medical certificate. In Kenya, we've been very active as part of a group of co-petitioners suing the government for its failure to protect civilians during the post-election violence period. We also do a lot of advocacy on reparations and many other issues that our partners have identified. And lastly, I just want to mention that over the last 5 years, we have learned a lot from developing this program, and so we have made it a priority to disseminate our findings in peer-reviewed journals along the way. This is just a sampling of selected publications in 5 journals, medical journals, legal journals, that really help to explain what it is that we're trying to do. And while the program is not a panacea, it's beginning to help chip away at some of the barriers to justice, and we are beginning to see some changes in these communities, which is a great segue to Mike, because Mike has been tracking that evidence as best he can with his unique methods, and he's here to share some of those methods and findings with us.
Thanks, Karen.
And for those of you just joining, this is Dr. Mike Anastario, who leads our monitoring and evaluation efforts for the sexual violence program.
All right, thank you. When I first started working with the sexual violence program, I had worked previously in M&E for about 5 to 6 years, and on training programs in particular, I had seen that a lot of training programs were using their M&E efforts to perform for funders. And so from an evaluation perspective, that's not very exciting. That's not very aimed at understanding. It's aimed at performing. And so when PHR came forward with this effort, they were interested in an evaluation where they were also able to learn from what was gathered during the evaluation, and they were interested in research. So that's why I was particularly interested in it. And so what I've seen in training program M&E this is sort of an epistemic financial spectrum, and what I mean by that are ways of collecting data for M&E that correlate with budgets. And so at very basic levels of M&E for training programs, where you have very limited budgets, maybe you have a program personnel actually conducting their own M&E, you see very basic monitoring. Sometimes they're just taking counts, sometimes they're using site visit notes, they're measuring training satisfaction, but nothing more than that. Sometimes you see more advanced M&E, but still within the M&E non-research spectrum, very low budget, where maybe you're doing pre and post training assessments to gauge changes in knowledge or attitudes, and you also have some basic follow-up on outcomes. But as we sort of move forward in that epistemic financial spectrum, where we have a little bit more budget and a little bit more science, we see quasi-experimental designs. Maybe we're using qualitative methods to assess outcomes or surveys of trained participants. And then at the very high end, so these dollar signs are based on real budgets of studies I've worked on. Something that's 10 times more expensive than a base M&E effort is where you're actually implementing a randomized controlled trial. So you have a very nice scientific design, you have an intervention group, a control group, you're estimating an effect size. But those endeavors tend to be very expensive, they're very resource intensive. You tend to have a research team in place that's working full time as a research team. So again, as the program was beginning, that wasn't something that was really feasible for the program. So hearing that they wanted to do basic M&E and that they wanted something scientific, I tried to find something that struck a balance between research and basic M&E. And what we've come up with over 5 years, we now call grounded programming. And that's based on basic M&E and some science. And the assumptions that we work with is we have both qualitative and quantitative methods that are used to report and evaluate the program. We also use mixed epistemological paradigms. And by this, I'm talking about ways that we actually try to understand what's happening in the field. So yes, we do track, we do have a theory of change, and we do attempt to measure outcomes based upon that theory of change. But we also have this perspective that data might come in from the field that changes our theory of change. We're able to change with the data that's collected. So that's what I mean by a constructivist epistemological paradigm. Further, the overall goal of the evaluation is to actually inform programming. So by that, and I mean this is very basic, you would think that this is how evaluation works, but we have programming, we have a cycle of evaluation that then informs ongoing programming. So the programming can change. And if the programming changes, the evaluation is going to capture new outcomes. Okay, so there's that sort of iterative approach. Finally, we have the reality that the evaluation strategy produces discourse. It's going to be consumed by funders, and they tend to speak to the evaluation community or the evaluation team here through a log model. So our entire evaluation strategy can be placed on a programmatic log model. Quickly, for the program, we conceive that log model to include inputs that, in the context of training, would go directly towards training professionals in Kenya and DRC and elsewhere. Outputs include basic changes in knowledge, immediate changes that you would see following the implementation of training. Outcomes include behavioral changes in the trainees themselves as they go to implement what they've learned, and impact ultimately affects experiences of survivors of sexual violence. Okay, and we come up with ways to measure across this range of log model domains in conducting grounded programming. For us, grounded programming also includes formative research. And so what does that mean? We're trying to get an idea of what's happening in the environment so that we can actually inform not only the program, but also our evaluation strategy. And I'm going to give you very concrete examples of formative research that have come out of DRC and Kenya. So, for example, in DRC, at the very beginning of the program, we went in and did formative research, and what did we learn? There was explicit impunity. So a perpetrator could call a survivor, they could call an investigating law enforcement officer, they could directly threaten a physician, and that was the environment in which PHR began programming. We also saw material resource restrictions within occupational environments of physician, law enforcement personnel, and personnel in the judicial sector. We saw physicians were unable to conduct serological tests on survivors. We saw that DNA testing was not available in country. So if you have a training that's focused on collecting vaginal swabs and processing them in a government chemistry lab, that's not happening in DRC, so that evidence can actually be used in court. We saw that police lacked resources to investigate sexual assaults, and the legal sector couldn't, they lacked referral options for survivors who were coming in with great need. We also saw a complete lack of multi-sector coordination. So we saw physicians documenting conclusions of rape in the medical certificate, which would then be challenged in court. We saw the police were actually asking physicians to determine whether or not the survivor had been raped. And we also saw the legal sector not understanding medical terminology that was coming directly out of medical documentation. In Kenya at baseline, we saw that in much contrast to the DRC, there was the existing capacity to conduct DNA analysis. That being said, the government chemistry laboratory, which runs DNA analyses, was extremely backlogged. It's an extreme version of what we see happen here in the United States. So while the capacity was there, the backlog was overwhelming. We saw high personnel turnover in the law enforcement sector. So if you're training law enforcement personnel, this has implications for who you train and how you train them. Okay? We also saw slow judicial processing of sexual assault cases. Nonetheless, sexual assault cases were being processed. It was just very slow. Okay? And finally, there were knowledge and practice gaps. And this is something that was particular to Kenya. So you actually had physicians who were saying, yes, I know I'm supposed to use a pediatric speculum, but I don't have a pediatric speculum, so this is what I do instead. So you actually have gold standard knowledge, but inability to implement it in practice. Those types of formative research ultimately define and inform how we are able to measure outcomes and impact, because outcomes and impact will vary based upon those different environments. Okay, we can't sort of define one for both. Some of the early program effect findings that we saw earlier on in the first 2 years of the program was that the program was changing ways in which physicians focus on the survivor's narrative. Once you have a survivor's narrative well documented, it can be validated by other sectors, other investigational techniques, and we saw that physicians were beginning to document that as well as law enforcement personnel. We saw some improved understanding of medical terminology in the judicial sector. We just saw the implementation of multi-sector network meetings between personnel in the healthcare, law enforcement, and judicial sectors. They were just beginning to meet with one another. And we also saw them focusing on the program's reach into rural areas. As they began working on these things, they were saying, you know what, there's quite a difference between rural survivors and urban survivors, and the way that their cases carry out. We saw some of the forensic exam techniques that were coming out of training being applied to pediatric cases. We saw the beginning of the implementation of forensic photography in the DRC. This includes speaking with female physicians who said, you know, my husband has always taken pictures at weddings, but I just learned how to use a camera, and now I can take pictures to document forensic evidence of sexual assault. So I always thought that taking pictures was similar to taking pictures at weddings, but now I know what to do for a survivor of sexual assault. And we also saw the beginning of interagency communication with the government chemistry lab in Kenya. So you have the lead government chemist now speaking to law enforcement officers who are submitting forensic evidence of sexual assault to the laboratory. He's telling them what's happening, what's wrong, why are tests not turning out as they should, why is evidence being rejected. But you start to see that communication occur between sectors. Then in 2015, we had the UNTF, the United Nations Trust Fund to End Violence Against Women Impact Analysis. And that impact analysis requested evaluation in 6 domains: program effectiveness, relevance, efficiency, sustainability, impact, and knowledge generation. And we essentially said, okay, well, this is a reality. It's a funder that's asking for these specific outcomes, and we have our current strategy here. So we married the two. And starting in 2015, we developed a hybrid evaluation strategy that continued to do grounded programming, but which captured domains relative to these 6 put forth by the UN during the impact analysis. And you know, previously we were wondering in which direction we should go with M&E. Should we take an implementation science framework approach? And the UNTF impact analysis lent very well to an implementation science analysis, especially with regard to relevance, efficiency, and sustainability. So we chose to use these 6 domains and marry them with our current evaluation strategy as we move forward. So in the interest of time, I'm just going to present results to you from both DRC and Kenya using mixed qualitative and quantitative methods that speak directly to program effectiveness and impact. I wish I could cover all 6, but it would take quite a bit of time. So here we see knowledge change among PHR training participants in Kenya and DRC. And we do see positive impacts on knowledge, although as you can see, they are slight. The greatest impact that we see is actually in knowledge of not measuring the diameter of the hymen to determine whether or not there was vaginal penetration for child sexual assault cases. Okay, so we actually see physicians and clinicians shifting their focus away from that in clinical practice. But again, these changes in knowledge are very slight. They don't really speak to the richness of what the program has done. In DRC, behaviorally and qualitatively, we've documented changes in documentation practices, particularly around physicians who are now documenting the survivor's narrative, which can be cross-validated with observations coming from other sectors. We've seen a patient centering of care, meaning that now physicians are aware of F40 block diagnoses or anxiety disorders in patients that are presenting with sexual assault. They're talking about these things. They're talking about referrals for post-traumatic stress disorder, acute stress disorder, whereas that wasn't part of what was happening before the PHR training. We also see more thorough evidence collection procedures, particularly in child sexual assault investigations with use of the pediatric speculum and attention to child survivor needs. We see law enforcement personnel visiting crime scenes to cross-validate the survivor's narrative. This was something that, again, was not happening before the PHR training. And we see the implementation of some case management practices to help navigate survivors through multiple sectors as they're attempting to achieve justice. And then in terms of impact, and I'm going to talk about this qualitatively in a sec, but we've also seen courts now using evidence that are collected by PHR trained physicians, and we see practitioners who now have seen an entire case move through the justice system, and they're seeing their evidence be used in cases. That's very important. It reinforces the information that they've received from PHR and the way in which they've applied it, because they're actually seeing it be applied to justice. An unintended consequence of the program is that some of the PHR trainees are now receiving negative attention from perpetrators, and they report this changing relative to the PHR program. Because they're doing their jobs well, they're now being threatened more often. So that's a whole other issue that comes up in conflict zones, but it was an unintended consequence that was documented in the evaluation. This is an example, before I get to this, of impact, qualitatively measuring impact. So when we think about impact, how is the program actually translating into the lives and experiences of survivors of sexual assault? So this is an individual from the law enforcement sector, a police officer, talking about how the PHR training changed the life of a survivor. And he says, there is a case of a child, 6 years of age. The child was bleeding terribly. The child was brought to us. We took the child, and the child showed us the person who was the rapist, and this was the shoemaker. And this person said, I did nothing to the child. She is pointing at me because she knows me. After forensic examination, they found that the hymen was there, but the bleeding was so much. So the importance of the training was to bring the child to the doctors for investigation. Otherwise, before, we would have just arrested the shoemaker thinking he raped the child. So we had to look for what made the child bleed, and we found that it was a needle which was introduced in the vagina of the child. We continued investigation until we found that a person who lived in the same house with the child introduced the needle in the child's vagina. So this helped us not to condemn an innocent who was the shoemaker, but find who was the real perpetrator. So this is the way that PHR training translated directly into justice, in this case, for a survivor of child sexual assault.
And previously the shoemaker would have been blamed?
Yes. In Kenya, we've seen changes in the thoroughness of medical exams. So while there was some knowledge of forensic medical examination, they're now much more thorough. They're engaging in other, physicians are engaging in other forensic evidence collection techniques. We've seen the government chemistry laboratory actually observe changes in the way in which evidence is now being submitted. Prior to the training, you would have maybe a law enforcement officer grab a plastic bag off the street and put evidence in it and submit evidence using that plastic bag that's been collected from the street. Now, more gold standard practices are being implemented when forensic evidence is submitted to a crime lab. We see the justice sector relying on new types of forensic evidence, in particular the victim's narrative. They're not especially waiting for a DNA test, or they're willing to work with cases where there's not specifically a DNA test. They can use the survivor's narrative as forensic evidence. And we also see networks being used to increase the efficiency of case processing. So in this case, in Kenya, we see people across sectors using WhatsApp. It's a social media tool, but they're now using WhatsApp to communicate with one another and speed cases through, whereas they weren't doing this before. Nor could we have predicted it. I don't think we were even focused on WhatsApp or use of WhatsApp to facilitate cases, but it's something that's happening. Okay, and we've been able to qualitatively document it. What's interesting in Kenya is we see providers have the perception that there's increased convictions following training. Now this has quantitative implications. We haven't been able to quantitatively measure it yet, but this is something that's now emerging from the qualitative evaluation. We also see healthcare and police saying that they're receiving increased reporting. They have more survivors coming forward now than they did before. The assumption there is that they're seeing other survivors having their cases processed, and as a result, there's community knowledge that it's worth moving forward with the case. That's the perception. Again, we're unaware of whether or not there's true quantitative impact, but nonetheless, that's something that is now emerging in 2016, 2017 from the qualitative evaluations. And finally, we see standardization of language and knowledge increasing convictions, meaning that the justice sector isn't contesting documentation of the way in which something's been written, nor is there confusion about it, nor does a physician always have to appear in court, because now trained judicial personnel understand medical documentation that's coming forth in cases. They can process the cases much quicker. I'm going to show you an example of quantitative impact in Kenya, but to explain that, I just need to give you some methodological background on what was done. So to evaluate impact of the PHR training, we looked at survivors' medical records to see whether or not there's been significant changes relative to PHR program exposure. This is an example of a medical record review. I've redacted all medical records for this photo. What we do is we temporally sort the medical records by year, and then we systematically sample them, and we define the period at which PHR began training in the region. And we develop a database using those measures. Then we use an econometric technique to do time series analysis to determine whether or not there's been a significant change following PHR program exposure, accounting for autocorrelation in the errors. And what we've seen, I'm going to give you an example from one healthcare facility in Kenya, for example. We've seen quantitatively significant increases in documentation of the chief complaint in a survivor's medical record, the time of the sexual assault, the age of the perpetrator. These are all very important pieces of information if you're going to cross-validate a claim in a sexual assault investigation. We also have increases in whether documentation of whether the survivor bathed, whether an oral swab was collected, and whether a high vaginal swab was collected. What we've seen across all healthcare facilities that we've evaluated is significant increases in documentation of the age of the perpetrator and whether or not an oral swab has been collected. But this type of quantitative evaluation shows changes in the survivor's medical record, which can ultimately serve the survivor when they go to seek justice. Further, this has received a lot of attention, this methodology, because it doesn't, while we're trying to measure outcome for survivors, it doesn't require that we interview survivors about their sexual assault experience, thereby re-traumatizing them simply to do an evaluation. And this particular methodology has received attention outside of PHR. It's received attention from anthropologists who are interested in international criminal justice because it's capable, it's one way of measuring impact without re-traumatizing survivors. So it's been something that we've done twice now, and I think we're going to do into the future. It is a little more resource intensive. It does require a bit more of a budget, but it's ultimately where I think our evaluation strategy is going to measure impact. Is focusing on changes that we're actually seeing in records within systems. So not only talking about medical records that are in healthcare centers, but now thinking about changes in medical documentation that's appearing in the justice sector as survivors attempt to access justice. So we haven't yet done this, but we'd like to evaluate changes at that level in the justice sector. Ultimately, and this is a far-off plan, speaking to whether or not those changes correlate with changes in adjudication outcomes for survivors' cases. And that's all I have, so thank you.
Thank you so much, Mike and Karen. That was really helpful and really informative. So now we have time for plenty of questions. We have about 20 minutes. So everyone who's on the phone, we're going to unmute you. So now you are free to interrupt all of us and ask your questions. And also for those who are joining us here in the room, we'd love to get your questions as well. And then if my colleague would like, we also have some questions that were submitted during Well, I have a question. Oh, please, no, yeah.
No, I'm sure yours is.
No.
I'm Christina Lentz. I used to work at KHR years ago in Sierra Leone. And what I'm interested in this data. Thank you. I'm curious about two separate issues. One is, do you have any sense of how this has impacted criminal justice sort of processing generally? Because I would imagine what they're learning from violence documentation is bleeding into the rest of what they're doing. And there was a mention, I'm wondering if the prosecution of sexual, you mentioned it was slow processing some of these cases. Is there a problem with slow processing in other arenas as well, or is that specifically sexual violence because of the sensitivity and complexity around it? And my third question is the issue of pediatric cases came up a lot, and I'm just wondering what percentage are children of the sexual violence cases you're encountering. Do you have a sense of that? And is there advocacy of that happening through PHR, through other organizations? Is that just particular?
Yeah, so for those on the phone, a three-part question.
Yeah, sorry.
No. How this is impacting the justice process in countries where PHR is working, the speed of prosecutions and its uniqueness or not within sexual violence, and also pediatric cases. So either Mike or Karen.
Sure, I'll start and then pass it over to Mike, because these are great questions, and actually we would not know the answers to those questions had Mike not been doing those qualitative assessments each year in these countries, because that's the only way we can get this rich data beyond the work that we're doing. So so I know that Mike could speak to a lot of this as well. We are seeing that these processes, the coordination, lends itself not only to sexual violence cases, but other kinds of criminal cases. And there are very concrete examples of this that Mike has actually captured in some of these studies. So that's very heartening, because they're translating these best practices to other processes. The speed of prosecution, or rather the slowness of justice, is a huge challenge for us. One of the developments that we've seen the network undertake, both in Kenya and in DRC, is because now that they have access to colleagues in other sectors, in particular now that the clinicians, the doctors, the nurses, they know who to contact in the police or on the justice sector, they can follow up and track where these cases are at and even push for some of these cases to move forward more quickly. And Mike's reports also indicate this incredible development in Kenya where thanks to the sensitization of the training, the judges are now accelerating sexual violence cases to at least help those cases move forward more quickly, because they're more sensitized to the trauma as it plays out on the survivor. And then with respect to pediatric cases, it's a challenge to know what the actual percentages are, because of course many survivors don't report, and in the case of the pediatric context, many of the perpetrators are guardians or people that the children know. So they're more reluctant to take these cases forward. But in our conversations with the service providers, with professionals in the health communities, and with we're hearing that the percentage is somewhere between as high as 70–75% of their cases are pediatric cases. That number can be confusing though, because what constitutes a pediatric case can range. We see in DRC there's a host of cases where the children targeted are tiny. They're toddlers, they're babies. That's a certain kind of case. But we also see that there are many cases of adolescents in the 16 to 18 age, and oftentimes, and this is one of the challenges that many of our partners have identified, in those cases it's consensual relationships, but because of statutory legislation that constitutes statutory rape, and the families then use that to go after these kids. So it's a whole range, but we are seeing a very high percentage of pediatric cases, and we try to tackle those issues when we do those specialized pediatric trainings.
Yeah, and the only thing I would add is with regard to impact on the justice sector, not speaking to child sexual assault cases in particular, but just generally. What we see, and I'm just going to use DRC as an example, physicians providing testimony for a given case. Before, we had physicians describing great fear of being called into court and not appearing in court, and when physicians are called into court, they could have to take the entire day off from clinical practice. They might sit in the courtroom and never actually be called, and it was a huge waste of time. Now we see, with improvement of medical comprehension of medical lexicon in the judicial sector, we see less physicians being called forward to testify, so cases can move forward much more quickly, and we're not wasting physicians' time, or that's not what's happening. And in DRC in particular, where I think there was a lower baseline level of medical forensic knowledge, you now see, especially in the judicial sector, some of this training information being applied to other cases, particularly war crime investigations. So you'll have magistrates or law enforcement show up to crime scene and say, oh, wait, hold on a second. We have to put on gloves. Do we have a camera? And they're saying that this is happening as a result of being trained on forensic evidence in sexual assault or forensic sexual assault investigations, and that this wasn't something that they were doing before, but now they're applying it to basic war crime investigations. So it is something that we see. We're not systematically documenting it, but it's coming up in the evaluation.
And sorry, to follow up on that, what percentage of the cases that you're coming into contact with are work crime related, and what are just...
Yeah, the question is about the percentage of cases that are war crime related.
So I can field that. I think it varies from place to place. I would say the conflict-related sexual violence, we see more of that these days in DRC and in the more rural areas as opposed to urban centers. But that varies over time. And in the 5 years that we've been active in DRC, we've seen that that percentage be in flux, depending on the political vicissitudes there. In Kenya, of course, there are conflict-related sexual violence, which is what prompted us to engage in Kenya in the first place. And that has receded over time to a higher percentage of community-based sexual violence. But as with each round of elections coming up, there's a lot of concern about what conflict-related sexual violence might look like. And so what a big element that we've been doing with our medical legal networks in Kenya now in preparation for even the August national elections in that country is doing a lot of work on preparedness and how to be engaged in a prevention opportunity, and then also how to engage with each other very quickly in the event people are seeing an increase in conflict-related sexual violence around the election.
Thanks. More questions? Yeah, please.
I'm Allie. I'm with Cardozo Law School's Human Rights Institute. I was interested in how you see all of the, particularly the Medicap application and all of your training applicable in other settings and other conflicts, particularly in Syria and Iraq, and when there are multiple perpetrators. So, for instance, I'm thinking about the sexual enslavement of the Yazidis, and as girls are rescued or escape, how you think that these programs that you're developing can be applicable for them.
Yeah, so the question was just about the applicability of PHR's programmatic work, including things like the Medicapped app, to other conflicts. You mentioned Syria, as well as Iraq, and the Yazidi case as well, in terms of multiple perpetrators.
Yes, thank you for both of those questions, actually. So with respect to the issue of mass crimes more generally, so whether or not they're conflict related, we see mass crimes, for example, in both Kenya and DRC. So we do a lot of work in our training, not only how to improve evidence gathering in individual cases, but how to aggregate that data and be able to extrapolate patterns of violations so that you're able to more effectively document cases of mass crimes. And that's really important to show even a command responsibility or widespread and systematic cases for crimes against humanity. So that's something that we're doing in a low-tech context through even just the standard form, but also Medicapped allows us to take that to a higher level to aggregate de-identified data to be able to determine that data across a geographic location to be able to also determine patterns of violations. So important to proving those mass crimes cases. The second question about adaptability of this model to other places is really important. And as we are concluding our 5th year of this work, we are very much thinking about how can we take these lessons learned to new contexts. And so we are in the throes of scaling up to new places. This past year, we started to do some work in Central African Republic, which has been very exciting because we've been able to mobilize our partners in DRC to help us do that work in CAR, which is terrific, and it also helps support a regional network and communities of practice, which is really helpful. And you had also mentioned Syria and Iraq. PHR is also, there's a team that has been very active in northern Iraq for the last several months, trying to assess what aspects of our work on the sexual violence program can be applicable to that very different context out of Africa. And so we're excited to be able to test out what aspects of the program are universal and what aspects need to be customized for very specific contexts. And we're hoping as well to take this program beyond to other places in Latin America where there's been some interest as well. So I think that we're on the precipice of all of this, of testing this out in new places. So it will be very interesting to see what we learn and to compare and contrast it with the data that Mike has already gathered from these two countries.
And Karen, if I can, how do you use the data that Mike is able to generate when you think about scalability, when you think about changing the program, when you think about adapting it to other contexts? What is it that you're learning from Mike's field work that helps inform that decision making?
I think one of the things that has been extremely useful is to understand which aspects of our interventions are very useful to people. So for example, after every training, we always provide our service providers, the participants of these trainings, with forensic backpacks that has a range of very low-tech tools, tape and paper and things that they're ultimately able to also access in their communities. And we provide that to them to help them feel launched to be able to be equipped to do this work back in their places of work. And we never could have known how useful those forensic backpacks are. But thanks to Mike's data gathering, we have seen that, in fact, this is much more useful than we would have anticipated. Things like this lexicon. This is that little booklet that translates medical jargon into language that's accessible to non-medical practitioners. We never could have anticipated that this is something that would be so transformative to people. The other piece that I would say that has been an unanticipated outcome is that just the creation of medical legal networks has been so transformative, not only to push these cases forward, as Mike was identifying through WhatsApp communications, which we're seeing just this explosion of communication, but also, and this is really what we could not have anticipated, really cultivating friendships among these practitioners. This work is so hard. These people are doing this work every day in isolation, and now they have a community of peers to talk to who understand how hard this work is. We've seen an enormous amount of vicarious trauma by these service providers. These cases are very tough. But now they have this whole other group where they can share their feelings with, and we're seeing that, and that is something that actually I would say for me has been one of the most heartening developments. I never would have anticipated that. And so as we think about scaling this up to new countries, I think we would think very deeply about how we would try to think about networks in those contexts.
Yeah, great.
And speaking of scalability, we did have one question about so evaluation in impact and conflict zones is difficult, and much of the work is not achieved over a short period of time. How would you measure and evaluate as you build out over time?
Yeah, the question is about measuring and evaluating work over time, just because of how difficult it can be to do this work.
Right, so I'll begin, but then I'll pass it over to you, Mike. So that's also a terrific question. One of the biggest challenges we've had is how do we even measure impact on survivors, which is an elusive group, and as Mike mentioned, we also don't want to re-traumatize them by asking them these questions. So even determining what kind of impact we're having now is a challenge, let alone the fact that we are trying to build systems to create change over time that we probably won't see for decades. So it's a long process with a long arc, but we are trying to be creative in the ways that we're trying to capture, at least in the interim, some of those outcomes, but lay the groundwork to be able to assess some of that impact. And so, Mike, I know that you've given this a lot of thought, and you've tried to be really creative and flexible to try to figure out what methods we can use. So I'll pass it over to you to share that. Yeah,
and in the first 5 years of the program, what we focused a lot on in the evaluation is actually implementation of how these things work as the program attempts to impact survivors in the justice sector. Had we begun in 2012 establishing a baseline quantitative measurement of number of convictions, we probably would not have shown much impact. But now we have a much greater understanding of how impact operates. Even if you think about that vignette I shared on the child sexual assault case in DRC and how that was investigated, we can start to think about where the program is focusing. And so what we're seeing broadly, and I hesitate to even say that, in both DRC and Kenya is an increase in intersectoral referral, so law enforcement personnel actually bringing the survivor to the medical sector, and then changes in the documentation, the medical documentation affecting a survivor's case. So I think that over the long run, what we've learned from the qualitative analyses is that that's where we are going to then quantitatively focus, with understanding that that quantitative focus can't be the entire M&E effort. But again, it's something we've had to learn qualitatively.
Great. Hannah.
Hi, I'm Hannah Chandra-Gardner. Thank you. This was fascinating and really informative. So I have a question to Mike about how you present what you're doing when you're doing your field work, and what do the people that you're speaking with understand that you're doing, and do they see the value of this? And I imagine this is somewhat novel and somewhat different, and certainly the approach that the PHR program is taking is very different than any other organization. So how do you speak about that, and how do you get people to speak openly and buy into this and really share their experience with you?
Yeah, and this is something I didn't cover in the presentation, but it certainly comes up, and now it's coming up a lot during the evaluation, where you see this great appreciation for people seeing a repeat the same evaluator come in to repeat the same evaluation for the same program, and they say, this is actually really helpful. I remember telling you that we didn't have a pediatric speculum, and now I'm telling you how we're using the pediatric speculum. And you sort of see that happening, and this is something that doesn't happen frequently in implementation of evaluations in developing countries as well. Oftentimes, what I've seen in practice is some sort of collusion with the program, where you literally have doctors saying, "Okay, what do we need to do to help you get your funding?" like what kind of counts do you need? What can we do to grease the wheels to get your stats going? Whereas here, you know, I've interviewed some doctors now 3 or 4 times, and they really, in this, you know, on their 3rd or 4th evaluation, they're not just saying, oh, PHR is great. They're saying, you know what? If we were to do pediatric trainings in this rural zone, what do you think about ketamine administration? And what do we know about ketamine administration? But they're really thinking, and they're trying to feed information to the program to get some sort of response. So, I mean, I've seen, as an evaluator, I've been really impressed. I think it's increased the richness of the data that we're able to collect. We're able to get much more specific, sort of beyond that superficial approach. It was very difficult in the first years because people just wanted to say positive things about PHR, and I really had to dig during the interview. Whereas now I can just sort of sit there and I get very specific information, especially from the repeat people who have been evaluated. So, but again, like that's something that I've seen them be very appreciative of PHR for, because it's not something that's done typically by programs implementing in developing countries or at least developed countries. So,
That's a great question. So we're running a little short on time. If there are any additional questions, I know Mike and Karen are generous with their time, of course, and can hang out a bit. Were there any other things from the phone?
We can open the lines up one more time, but
Yeah.
Trends are emerging, and there's greater awareness generated from your work about the level of sexual violence. I'm just wondering what sort of advocacy efforts are going on, you know, in conjunction with your data or separately from government or NGOs in the area. Like, is that beginning to happen? Or is it already in place? And does PHR have involvement with that?
Yeah, the question's around advocacy that relates to our work and other NGOs and governments.
Advocacy in an effort to educate against sexual violence.
Yeah.
Sure. So I think it looks different in Kenya and in DRC. For sure, there are many other civil society organizations whose whole mandate is to be out there in the communities sensitizing men and boys and women and girls on their rights, their responsibilities, and that work is so important because we're only one piece of the puzzle, so we have to work within that larger system and collaborate with all of these other NGOs who are working on many other pieces of the puzzle. What we've seen in terms of advocacy, though, is that one of the benefits of working so closely over 5+ years, almost 6 years with these partners in these communities is that the doctor, the nurse, the psychotrauma counselor, the police officer, the lawyer, the judge, they are now the advocates in these communities because they've been so sensitized over time. They see the impact that the way, they see, first of all, the impact on the survivor. What happens when a case is not being coordinated well and the survivor really suffers. And they see in the alternative how the survivor benefits when people are treating her or him with more respect, with confidentiality, there's more coordination. And I think that experience has created these incredible champions in these communities to be the leaders and the advocates in their communities. And they're taking that not only to push forward specific cases to move more quickly as advocates, but also to implement reforms at the national level as well. So that's been very exciting, and to the extent that we're able to, we support that.
Well, thanks to everyone here in the room, and thank you to those who joined on the phone, and especially to Karen and Mike. Thank you both so much. It was great. And there's food, not for the people on the phone.
Very impressive to communicate all that in one
Thank you for coming.
Yeah.
For all your time. I know.